And it's now my great pleasure to welcome Claudia Sommer to the conference. I know you've been here earlier this morning, Claudia. You've had to leave to participate in other meetings, but it's a huge honour for us here in Scotland to welcome you as the current president of the International Association for the Study of Pain. We're humbled that you've given us your time. We're very much looking forward. I've worked with Claudia as when she was a member of the Neuropathic Pain Special Interest Groups. I've seen her work very well. Of course, she's moved on to bigger and even better things than NUPSIG just now in her current role. She's also clinically and academically based at the University of Würzburg in Bavaria. And IASP isn't enough for her. I see she's president-elect of the Deutsche SPaRC Gesellschaft. So another one to add to your portfolio. But today you're going to talk to us about mechanisms in fibromyalgia. So Claudia, if you're ready to take the stage, I'm privileged to hand over to you just now.
Okay, now it should work. Can you see it now?
Yes, yeah.
Okay,
Perfect.
okay. So, again, thank you very much for having me at your conference. And just one little correction, I'm past president of the German Pain Society, so that's done.
My apologies.
One task done, which is good. So today I'll tell you about our research on fibromyalgia, which really goes from nerve to brain, and also nicely links in some aspects to Karen's presentation just now. You all know what fibromyalgia is, what we call the fibromyalgia syndrome, and you know the definitions with the chronic widespread pain, the tender points that we still look at but don't need anymore for the diagnosis, and the associated symptoms, which can be many, starting from unrefreshed sleep over cognitive symptoms and autonomic symptoms, you name it. And there are lots of prejudices around fibromyalgia. So it's usually the middle-aged woman who comes into the office and wants to talk about the symptoms all the time. You cannot even change the subject. They're either depressed or overactive. And this is why the patients are not very popular with most specialists, which gave rise to articles like this one in Pain. No one wants to look after the fibro patient. And this is how the patients usually come to you if you agree to look after them, saying nobody understands me, nobody wants to take care of me. And it's not a rare condition. As always, I'm not sure about these epidemiological data, but 1 to 3% of the population, at least in the Western countries, seems realistic. Not all of them are severely ill, but part of them are. The pathophysiology is a big field of discussion, like always, when we don't really know. And some are saying it's the result of a central nervous system malfunction, which results in amplification of pain, transmission, and interpretation. Others say it's just a kind of depression. Others have said that it depends on peripheral as well as abnormal central processing, or that it's just in general a disorder of pain processing. And yet other papers have said it's a heterogeneous condition, and patients fall along a continuum with, on one end, a purely peripherally driven painful condition, and on the other end, a centrally driven pain. And please remember this, because I'll come back to this during my talk. And what are my views and interests? So I acknowledge there are changes in the central nervous system, but I wonder whether they are primary or secondary. There are also changes in the afferent nociceptors, but what is the cause? Why are women so much more affected? Is this related to autoimmunity, because women have more autoimmune diseases in general? And of course, depression and the affect plays a role, as in any chronic pain. And also, I'm convinced there must be subgroups. And these questions are what lead me to study this condition and to try to get some scientific evidence there. The central nervous system changes have been shown for quite a while. This is one of the earliest papers in 2002, fMRI, showing that if you use the same pressure stimulus in a normal control and in a fibromyalgia patient, the fibromyalgia patient perceives a lot more pain, and in the brain of the fibromyalgia patient, you see more activity. One study that interested me very much was this one by Harris and their group from 2007, a PET study using a tracer to look at the availability of the mu opioid receptor in the brain. And they found that this availability of the mu receptor is reduced in the fibromyalgia patients. Small study, not very many, but they could show it. There were several interpretations of this finding. So one was, oh yes, now we know why they don't respond to opioids, because they don't have the receptors. The other was, oh, their endogenous opioid system is so much upregulated because of the chronic pain. So this is why these receptors are not available. Whichever way you look at it, we thought we found a nice link to the neuroimmune system. Also, like studying the central nervous system, many people have studied the immune system, the inflammatory system in fibromyalgia. And we and others found that there is an imbalance between anti-inflammatory and pro-inflammatory factors systemically in these patients, with a lack of anti-inflammatory factors. This is our study where we looked in the blood of 2 separate patient cohorts with fibromyalgia, and we studied their interleukin-4 and interleukin-10 at the mRNA level and also at the protein level. And with each method, we could show that the patients have lower levels of these anti-inflammatory cytokines. And then we came upon this basic science study that in a dish showed that to upregulate your mu opioid receptors and to put them into the membrane, you need interleukin-4. So we thought, oh wow, our patients don't have enough interleukin-4. This may be the cause why they don't have enough opioid receptors in their brain and why they have the pain. So the idea was that we do our own PET study to replicate these data, and then in addition correlate the mu opioid receptor expression with the IL-4 levels in our patients. So remember this. To do this, we recruited a new cohort of fibromyalgia patients. You see them here. And we recruited a disease control group of patients with major depression, but without pain. And we did some tests with them to exclude a peripheral neuropathy. And of course, questionnaires. You can see the fibromyalgia patients have pain, the depression patients and the controls do not. In a depression scale, the fibromyalgia patients and the depression patients are about the same, and the controls are lower, of course. Since the PET study couldn't start right away because we needed a collaborator, we didn't have the equipment here. So we thought, well, we might use the time and do some other things in between. And we did a study with near-infrared spectroscopy. It's a nice non-invasive method where you use these optodes on the head to look at the oxygenation of the blood, which is an indirect measure of brain activity. You can only measure superficial areas of the brain. That's the disadvantage. But it nicely You can do a time course because you can look 1 minute after the other. And the other advantage is patients don't need to be in a big scanner like in fMRI, and they can do tasks and they are not afraid. We applied this pressure stimulus, and we asked for the pain threshold, and the pain threshold, as expected, was much lower in the fibromyalgia group than in the depression group and the controls. But the pain intensity at this threshold was quite the same or even higher in the fibromyalgia patients than in the controls. And looking at the NIRS results, you can see that on the contralateral side, so this is the left, we stimulate it on the right, so you expect the left brain to react. On the contralateral side, we see more activity than in controls or our depression patients, but also on the ipsilateral side, where you normally don't see anything, you see some activity in the fibromyalgia patients. So we had confirmed that somehow stimuli from the periphery, even if they are lower than in controls, cause more brain activity in the respective areas. And then we thought, and this was in particular my then postdoc, Nurcan Yücel, who's now a professor of her own, we then thought, well, where in the path of pain does this augmentation happen? There is an augmentation somewhere, but it could happen right in the periphery, somewhere in between, or right in the brain. And we tried to study this. The first thing we did was quantitative sensory testing with the usual stimuli. And to our surprise, the fibromyalgia patients had quite marked deficits in the detection of cold and warmth and differences in temperature, also in detection of the von Frey hairs here. And they were hypersensitive to mechanical stimuli as expected. So this pattern with the deficit in temperature detection, this is more like what you would expect in a neuropathy, especially a small fiber neuropathy where the A delta and C fibers are affected. Since QST is a psychophysical method where you need the collaboration of the patients and their reaction time plays into it, we needed more objective methods, and one of them we used was the pain-related evoked potentials. These are electrically evoked potentials. This is an electrode that mostly excites the A delta fibers. You can control for this by the nerve conduction velocity that you elicit, and you stimulate at hand, foot, and forehead, and you record from the skull. You get an evoked potential, and this has a latency and an amplitude. These are controls. In patients with small fiber neuropathy, for example, the latency is prolonged. So we did this with our fibromyalgia patients, and you can see here that no matter where we stimulated, the amplitude was reduced. The latency was okay in contrast to the small fiber neuropathy, but the amplitude of the potential was reduced compared to both our control groups. And finally, we took skin punch biopsies from the lower and upper leg. We stained and counted the intraepidermal nerve fibers. And in the fibromyalgia group, the median nerve fiber density in the epidermis was lower than in our controls, whereas in the disease controls, it was not different. You may see here that there's a big variability. There are some fibromyalgia patients who seem to have a normal skin innervation and some have a really low skin innervation, and I'll come back to that later. So we published this in 2013, and in the beginning we got a lot of criticism. How can you publish this? Fibromyalgia is a psychological disease. It's a disease of the brain. How can you publish this with just an N of 25 in each group? And so we were very happy when in the same year and in the next year, many other groups independently showed the same findings, like Anne-Louise Oaklander's group from the US, Marina De Tomaso from Italy, another group from the US, a group from Greece, and there were more. So this was very nice to see our findings confirmed in such entirely independent cohorts and from independent investigators. And a very interesting paper came out from the group of Jordi Serra, who does microneurography. So he did not look at these fibers morphologically, but neurophysiologically with single fiber recording. And his control group was small fiber neuropathy. So you have here the pain drawing of the fibromyalgia patient, pain everywhere, and the small fiber neuropathy patient with burning pain in hands and feet, typically. And recording from the C fibers, they found spontaneous activity in the fibromyalgia patients and the small fiber neuropathy patients, which you would expect because spontaneous activity in C fibers sort of equals pain sensation in humans. And looking at a mechanical sensitivity in both these patients groups, the C fibers were sensitized. But there was a difference between the patient group, such that the activity-induced slowing, which is a special characteristic of C fibers, a normal characteristic of C fibers, that they become slower in their conduction. They are slow, but they become even slower upon activity. And this slowing can be measured. So the normal controls have this kind of slowing, and the fibromyalgia patients had an even more increased slowing of their C fiber nerve conduction velocity, whereas the small fiber neuropathy patients did not have this. So we talked about this, and Jordi Serra said, well, one explanation there could be is that the C fibers in the fibromyalgia group are too thin. And why don't you look at that? So then my postdoc, Katrin Doppler, took up this task, and she recruited a new group of fibromyalgia patients, of small fiber neuropathy patients, and controls. And so you can see their demographic data there. She did skin biopsies, did electron microscopy with these. You can nicely see nerve fibers in the skin with electron microscopy. So here are some myelin sheaths, and these are the unmyelinated fibers in their Schwann cells. You can measure their diameters, and she did this in a blinded manner. And you can already see here the control has this nice, relatively large C fiber. The fibromyalgia patient has this small, round, dark C fibers, and quantifying it for biopsies from the distal leg, proximal leg, and finger, which we added this time. You see that at each site, the fibromyalgia patients have a reduced diameter of their C fibers. So this was interesting, but why do they have this, and why do they have reduced skin innervation in the first place? One project we used to look at these questions was associated to an EU consortium, which was called NC-RNA Pain. And there we were able to do large microRNA arrays because the consortium was centered on non-coding RNAs. And we identified some that were different in the fibromyalgia skin compared to controls. And among those, the RT-PCR verification identified LET7D as one that could be verified. It was decreased in white blood cells of the patients, and it was increased in the skin of the patients. Then, doing a database search for the targets of this microRNA, we identified insulin-like growth factor 1 receptor, IGF-1R, as one of the targets, which would make sense. And my doctoral student, Matthias Leinders, he investigated this. He then indeed found that in the distal skin, the more affected skin of the fibromyalgia patients, the IGF-1R expression was lower than in the proximal skin and than in controls. The ultimate test to see that this is real would be to measure the protein, the IGF-1R protein. We didn't have enough material to do any ELISA or Western blot, so we could only do immunofluorescence, which of course is at best semi-quantitative, but doing this semi-quantitative analysis, he did find that in the distal skin with reduced skin innervation, the IGF-1R immunoreactivity was lower. So we postulated that a prenatal stress or a later life event might lead to this upregulation of this microRNA LAT7D, which would lead to a reduction of the distal skin IGF-1R expression, which would lead to impaired regeneration of the intraepidermal nerve fibers, and thus to the intraepidermal nerve fiber pathology that we see and to pain. In the meantime, we have collected a lot more fibromyalgia patients, and in 2019 we had these 117 patients where we also did the skin biopsies distally and proximally. This time we had a different disease control groups. This time they had major depression and pain because the reviewer wanted us to do this. So, but I'm going to show you here mainly the results of fibromyalgia versus controls. These are the skin innervation results. Let's start with the controls. In 82% of the controls, the skin innervation is normal. Okay, 13% of the controls have a reduced distal skin innervation. It happens. They have no symptoms whatsoever, but it's a finding. Very few have a proximally reduced skin innervation or even both. In fibromyalgia, 37% have a normal skin innervation, 17 distally reduced, 31 proximally reduced, and 15% proximally and distally reduced. And interestingly, this group was also more severely affected by all the questionnaires and scales that we used. So skin biopsy is minimally invasive, but it is a little bit invasive, so it's better to have even less invasive procedures. This is why we also used corneal confocal microscopy, where you could see the corneal innervation, and you can measure several parameters, and all of these were also reduced in the fibromyalgia group compared to the controls. And we used our pain-related evoked potentials again, and as before, the amplitudes were lower than in the controls. This time, we had the chance to have Jordi Serra come to our lab and investigate our patients. Our patients speak German and he does not, and they were not allowed to speak in English or Spanish to him. So he was completely blinded as to whether they were controls or fibromyalgia patients. And he could confirm the findings that in the fibromyalgia patients, the C fibers had more spontaneous activity and increased mechanical sensitization compared to the controls. Now, let's go back to the brain. It has previously been shown that cortical thickness in voxel-based morphometry in MRI, cortical thickness is decreased in chronic pain. This is not new. And we studied fibromyalgia patients and controls in the scanner, and we found the same. So a decrease in cortical thickness in the left pars opercularis of the frontal cortex in our fibromyalgia group. And then we thought, well, if there are subgroups, if there are two ends of the spectrum, remember what I told you in the beginning, the paper by Sluka and Klau, where they said that there's a spectrum, some have the peripheral pathology, some have the central pathology. And this was also our hypothesis. So we thought those patients, those 15% that have the really reduced skin innervation, they would have less CNS changes. So we compared them to these 37% who had the normal skin innervation. And what happened? The opposite came out. Those who have the most pathological skin innervation also have the most pathology in the CNS. So far for the two ends of the spectrum, no, those who are more ill in all respects. Okay, you may remember that in the beginning I told you we wanted to do a PET study, and then I brought you through a long detour over a number of studies, but not the PET study. Well, this was real life because it took a long time. It took several collaborators, and in the end, we could only include very few patients. It was very difficult, but with the few patients that we could include, we could at least replicate the Harris findings of the reduced opioid binding capacity in the fibromyalgia patients. And we could also show that in the subgroup with the higher interleukin-4, those patients had a higher opioid binding capacity. This is the finding is hampered by the fact that the ends are really, really small in this group, but at least it did support our hypothesis for once. Back to the skin. Now that we had the large cohort of patients, we wanted to learn more, and I'm just quickly going through a few more results that we had from this cohort. So one was the blood vessel innervation in the skin. You may know that pain patients very often complain of disturbed thermoregulation in the hands and feet, and in the fibromyalgia patients, the innervation of the blood vessels was also reduced. Or another line of research was that we thought if we analyze the skin as a whole, for example, in gene expression studies, we lump different cells, right? Keratinocytes, fibroblasts, nerve fibers, Schwann cells. So we separated them in primary cultures for keratinocytes and fibroblasts, and then analyzed these cultures separately. And for example, in the fibroblasts, TGF-beta, a cytokine, was increased in fibromyalgia, and also some channels, some ion channels, and some ephrins, and I'll come back to those, were increased in the fibromyalgia fibroblasts. And in the keratinocytes, we found an increased interleukin-10 and also some of these ephrins. So why are we interested in these ephrins? This is a family of receptor tyrosine kinases, and they are axon guidance molecules. And some of them attract the axon growth cone, and some of them repel it. Now, in our skin, we regenerate all the time because we lose our epidermis, so we also lose our intraepidermal nerve fibers. They have to regenerate all the time. And normally they do, because the attractants and the repellents are in a balance. And we think that in fibromyalgia, this balance between the attractants and the repellents is disturbed, and this is why the regeneration of the intraepidermal nerve fibers doesn't function, and in the end the patients have a reduction of their intraepidermal nerve fiber density. Okay, this leads me to the end and to my simplified model of fibromyalgia pathophysiology. I do believe there's a genetic predisposition, although we don't know the genes, but there are many families with the disorders. Adverse life events play a role. What they do exactly, we don't know, but probably they have an impact on the immune system. So they might lead to this pro-inflammatory cytokine profile and to the disturbance of the axon guidance cues and neurotrophins. Then lifestyle, vitamin D, epigenetics may all play a role. And in the end, this damages the C fibers. They are hyperactive, they have ongoing activity, and this ongoing activity is played back to the brain, where in the end it leads to the altered CNS processing. And the whole chain doesn't end here, but it's a circle. It may go back and influence the periphery back from the CNS. So in summary, we now know from the large cohorts, ours and others, that about 50% of the fibromyalgia patients have peripheral small fiber pathology and dysfunction. We have sensitive methods to pick this up. We could confirm the CNS changes in the fibromyalgia patients, but it was more prominent in those that were affected in the peripheral nervous system than in those that were not. Thus, peripheral nervous system and central nervous system pathology are not exclusive, but present in patients with severe fibromyalgia. And we have also shown that neurophysiological and molecular parameters differentiate fibromyalgia and small fiber neuropathy, so this is by no means the same disease. And we know that inflammatory mediators and axon guidance cues are involved. We do not have the whole picture yet, but we have enough to ask more scientific questions and to fill in the gaps. Right, this was work of many people. I mentioned some of them on the way, but I want to show some more here and some collaborators, and also the grant agencies who helped us perform this work. Thank you very much for listening.
Wow, thank you very much, Claudia. That's an amazing talk, an amazing series of experiments that you've presented, and combining, reaching a convincing model of fibromyalgia in a condition that we always tell our patients we just don't know what's causing it. So thank you very much indeed for taking the time and your experience to bring us that today. I'm going to ask one question, and then we'll have time for one more. And my question is an methodological, practical one. Given that we always say we can't, there is no test for fibromyalgia, that's what we say to our patients, there's no blood test for it, and yet you've convincingly shown us that there are big convincing differences in all sorts of domains between fibromyalgia patients and the controls. But my question is, how do you convincingly ascertain fibromyalgia in your experimental cases, particularly when you're faced with the comparative group, which is major depression and chronic widespread pain, which might easily be called fibromyalgia by some clinicians?
Yes, very good question. Indeed, we use the ACR criteria, and to be really strict, so far we have used the old, the 1990, and the new ACR criteria. So they both had to be fulfilled to have the case definition as good as we can. I know many patients come and they have heard something and they say, oh, don't you have a test for fibromyalgia? Can I have this test?
Sure.
And usually they mean the skin biopsy. And I have to tell them, first of all, there's no test for fibromyalgia, because in many other disorders you have a reduced skin innervation. Yeah. And second, there is a 50% chance that you are normal in the skin. So.
Okay. Thank you. So there's one question which is also interesting from Sam Singleton, who's asking if there's any studies looking into the role of other opioid receptors, such as delta in fibromyalgia. And I would find this interesting. Do you know if placebo analgesia is also reduced in fibromyalgia patients?
Yes. So delta receptors, not that I'm aware of. Most certainly not a PET study. If there are any other studies, I don't know. Placebo analgesia, Yes, there have been studies that show this, but on the other hand, in the big trials with duloxetine, pregabalin, you name it, the placebo response was big, which also leads to these not so perfect NNTs. We recently did a small study with magnetic stimulation, TMS, and we also had a huge placebo response. So in my own experience, no.
Okay, thank you very much. That's really brought us right up to time. What a perfect end to a really good day of research. Claudia, on behalf of NHS Research Scotland Pain team, I'm very grateful to you once again for giving us your time and expertise to round our conference off, and I hope you've enjoyed listening to some of the other research that you've been able to do that. So thank you very much indeed.
Thank you very much.
Okay.
Excellent. Thank you very much, Blair, for that. And thank you, Claudia, for a really thought-provoking and interesting presentation. And as with David, we will be sending you a little token of our appreciation along with one of our coveted SPaRC rosettes. We'll be reaching you in the post at some point. So I despite some IT glitches, which have been a little bit more problematic today than when we did this in December for some reason, I think it's been a really great range of talks, lots of stuff to take away, and maybe some new collaborations to develop. I'm just going to share my screen and announce the prize winners. Let's just move it. Here we are. So prize winners from our oral presentation and also from the poster presentation. So not quite the same as an Olympic gold, but you know, we all have to aim for something. So the oral presentations were judged by members of the steering committee, and we've got two winners. I can move this down. There we are. So hot off the press, Carol Torsney from Edinburgh and Harry Heber from our research group here in Dundee. I'd like to say that neither Blair nor myself were involved in the judging committee, so hopefully unbiased. So congratulations, both Carol and Harry, if you're still here. A little round of applause from the audience. And for the poster presentations, which was People's Choice, so you've all voted on those, Lesley Green and also Cass McGregor. Now, Cass, I know you had two posters, and they both scored the same, so it's for all your posters. So again, for the oral presentations, we will send out the rosette plus a gift voucher, and for the poster presentations, you will get the rosette to hang on your wall. So just before we leave, and we will finish in time because it's a Friday afternoon, I think today, you know, we've had some really interesting discussions and research and quality improvement work presented, and I'm quite proud of what we're doing in Scotland in terms of how we start to address research gaps and work together to develop research networks and collaborations with clinicians. And you know, I don't think there's there's you know, that link between research, quality improvement, and implementation, I think, has been illustrated really well in some of the work that's been presented today. And I'd like to thank NHS Research Scotland for supporting us and providing us with a way of coming together as a group. One of the things moving forward that I'm really keen to do is to, we've had an excellent presentation from our patient partners on the steering committee today, but is to develop a more formal Scottish-wide group working with patient partners to help us set our research priorities in Scotland and work with us both pre-funding and funding in developing our research within Scotland. So 2011 SPaRC ASM is about to come to an end, so obviously the next thing on the agenda is we have to think about the next meeting. And I'm really keen that we will have a face-to-face meeting. Hopefully, if the technology and the funds allow, we will be able to allow a hybrid option. So those of you who are unable to attend face-to-face may be able to join us. But I think we're all missing meeting each other and we're aiming to try and bring it back to the spring, probably not in March, but hopefully in April of 2022. So keep an eye on your emails and on the NRS website, where we'll post updates about that. And I'd just like to finish by acknowledging the organising committee, the steering committee, who have always have, it wouldn't be possible without them, but also very particularly Jackie Pearson, our NRS portfolio manager. Those of you who've been presenting today will have met her, because she puts in a huge amount of work behind the scenes to make sure that things run as smoothly as possible. So thank you very much, and look forward to next year. And if I can get my technology to work, I'm going to finish with some applause. Yeah. Thank you very much, everyone. Have a good weekend and safe trip home.